Hi, my name is Michael Chikeen. The smartest people I've met have one common belief, that us silly humans really don't know much. For example, we still don't know why planes stay in the air, or how Tylenol or even gravity works. Yeah, gravity. Look it up. In today's distracted, clickbait, misinformation age, I wish we could all be less certain, more humble, and a lot more curious. Admittedly, I've been known to struggle with all three. So no more, no less, this show is my attempt to be that change. Thanks for joining me, and here we go. Hey everybody, welcome back to No More, No Less. I'm your host, Michael Chikeen, and today with me in the virtual studio, I have Dr. Bolad with me. The good doctor is a triple board certified physician, certified by the American Board of Internal Medicine in Cardiology, Interventional Cardiology, and Internal Medicine. He has over 20 years of experience in cardiology and the management of cardiovascular disease, and has a total of over 30 years experience as a physician. Dr. Bolad is on a mission to use his knowledge and experience to help the public, bringing them up to date and keeping the public informed about the latest developments in general medicine, which we will surely discuss today. So with that, Dr. Bolad, welcome to the show.
Thank you very much, Michael, for inviting me. It's a pleasure to be here with you.
It's great. I wanted to start off with maybe give us some ideas or what are some developing trends you're seeing in your practice over the last, let's say, 5 or 10 years as it pertains to heart health and the general population. As we all know, the last several years have been atypical, to say the least.
Absolutely. Well, over the last few years, I would say there has been, at least where I practice here in the United States, there has been more awareness of heart disease and heart health. And I think part of it has been pushed forward or brought to light by the COVID pandemic because people started to talk about whether the virus affects the heart. And then, as you know, vaccination came on and people were worried about myocarditis and their heart health. So generally, I would say over the last 5 to 10 years, there has been more shift towards heart health and heart awareness, at least here where I practice. And this has been really propelled by the pandemic, the COVID pandemic. So this is what I see, what the general population is doing. I get lots of people coming either on their own or being referred just for heart examination and heart well-being. So this is a general trend really from the population-wise. Obviously, from the field of cardiology itself, there has been lots of technological advances over the past few years in regarding to treatment of coronary artery disease, which is the number one killer and number one disease worldwide.
Right.
Also in the treatment of valvular heart disease, meaning patients who have got valve disease like aortic valve disease or mitral valve disease. There has been lots of advances in treating these more, I would say, non-surgically, meaning you can do it percutaneous rather than opening people's chests, etc. Also, the imaging has improved a lot over the last few years. So there has been both like patient-driven and technological advances over the past few years in the field.
Okay. And now you say that the technology has been advancing. Is there anything that you're seeing that is in development that, let's say, AI has stepped into the field as far as diagnosing, or I would assume that stent implantation isn't yet done by robots, but where do you see the future of AI and cardiac technology going?
I think this is going to be a major step forward in the future because, as you know, as you can read, the amount of diagnoses that AI can come with you put the patient symptoms and give you like differential. And I think it's going to be a tremendous help for everyone, for the physicians, for the cardiologists, and also for the patients. So I think really look at it as a supplementary means for improvement of development and diagnosis and treatment. So I really excited about it because I have been reading about things like how AI has helped diagnose, etc., patients and helped the physicians as well.
Right.
So, regarding to stents and robots, I think there has been attempts still. I mean, still going the field, but we're not there yet. It's a complex issue of having implant stents by robots. But who knows? I mean, there are things that we said 20 years ago that will never happen, and it happened. I mean, things are happening. For example, I can tell you, it was like Star Wars when people used to have their watches and they could talk to people, etc. This
Right.
was just like something out of outer space. Now every one of us have got this capability. So that's what I mean by God knows what's going to happen in the coming 20 years. But certainly the technology is helping both the physicians and the patients.
Right. I guess maybe one way that it could help people, and let me know how this makes sense. Whereas, from what I've read about heart disease or even symptoms of heart attacks, it seems to present much differently in a woman than it would a man. So how could for one, maybe you could explain what the differences of symptoms are between those genders and between those sexes, and then maybe how AI might be able to help, or technology might be able to help diagnoses in the future.
So the classical symptoms of coronary disease and heart attacks, as most of people know, it is a sudden onset of chest pain, diaphoresis, feeling unwell, collapsing. The pain starts in the chest, goes to the arm, goes to the neck, goes to the back. Now, in women, these symptoms can occur, but also there are additional atypical symptoms as we describe them. It can be just like heartburn in women. It can be just like fatigue, unusual fatigue, feeling nauseous. So this complicates the diagnosis of heart attacks and coronary artery disease significantly. I think that with advanced technology, we will be using more and more of these modalities in the diagnosis. For example, in your electronic medical records, when the patient comes, they're going to ask you A, B, C, D, and E, which is a normal intake for any patient. And you are going to find in the electronic medical records that AI tells you, well, you have to consider all this. So although it might be not a common presentation, certainly with advanced technology and AI, these are going to be put up on the list rather than lower in the list. I mean, eventually we do diagnose of people with atypical symptoms with heart attack, but it might take like a bit more time, to diagnose it, because at the end of the day, we're going to do an EKG. At the end of the day, we're going to do blood tests, etc., and that is going to tell us whether the person has got ongoing active coronary syndrome or active coronary disease causing problems, causing the symptoms. So we will get to it, but AI will make it much more quicker and obviously beneficial to the patient in order to treat early. In patients with heart attack, there is this saying that we say every time, which is time is muscle. And this is absolutely true. Meaning that if you lose every minute, if you have got a blocked artery, patient has got a heart attack, every minute you lose, you damage the muscle. And if the damage has been sustained for more than 3 hours, then the muscle is dead. Whatever you do, you might just have like a fine tuning in order to improve the function, but so much damage has happened to the muscle that it is difficult to recover. So technology is going to help us a lot in this aspect, in that we can diagnose and treat the patients early, especially in patients with atypical symptoms, such as you mentioned, like in women. The presentation is sometimes atypical.
Right, because it seems like diagnosing some things, especially if you're in a clinic opposed to like in a larger hospital with more sensitive equipment. I had a friend not too long ago said he is every year he could go and get a blood panel, a cardiologist appointment, and all these things because he's pretty up on his health. And I think I hope I don't get this wrong, because he said the cardiologist said to him that he had a branch in his they did an I think an EKG, and then they did something else to get a little bit more information, and said there was like an arterial branch where the doctor told them, don't worry, it's fine. Sometimes these things fix themselves, but in people who are fairly active, it's normal. And he was freaking out for a few days and had to go back to the doctor to get him to reassure him. So I was wondering, like, it just made me think of how like hard it is to manage people's expectations when it's hard to even diagnose some of these things. Like, does that make sense? The branch?
Absolutely, absolutely. So, Michael, this is a very important issue that you touched on, and just let me clarify about the natural history of this disease. So, lots of people have got blockages to different extents. Okay, it doesn't mean that you have got a blockage to a certain degree, which is, if it is not severe and significant, that you are going to get a heart attack. As we alluded to initially in this conversation, the heart attack is like a sudden onset of chest pain, diaphoresis, you can't do anything. People describe it sometimes like an elephant on my chest, things like that. Mm-hmm. So it is, and it is painful. It's very painful situation when it gets the typical symptoms. So how does this happen? It happens that there is already an underlying disease, and for one reason or another, the lining inside the artery cracks open. Okay, it cracks and just like when you have, for example, a cut on your skin, you will find that you bleed and then a clot forms, right, in order to seal the bleeding. The same mechanism happens in the coronary arteries. So when this plaque cracks, it starts to heal by having a clot on it immediately, within minutes. And that clot, because of the size of the arteries, it blocks the flow of blood to the segment of the heart supplied by that artery, and that's why you get all of a sudden severe onset of chest pain, etc. So this is a classical presentation, and there are so many factors that can lead to this plaque rupturing and the healing process starting, stress, etc. But there is already an underlying pathology there. Okay. So why does this happen, and when can it happen? Nobody knows. That would be like $1 million question. Nobody knows.
Right.
Okay. Otherwise, we would have really known and treated people well in advance. So going back to your friend's story, you might have a plaque or a blockage in a branch, etc. You can never tell whether this is going to progress to a heart attack or not. So you can't be doing like tests every year, etc. It won't tell you much. It tells you that the blockage is there, okay, or tell you whether it's probably improved or worsened, etc. But
right.
It never tell you whether you're going to get a heart attack or not. The thing that we do for these blockages is that we start people on medications to try to stabilize the plaque. Things like, for example, cholesterol medications, like the statin medications, atorvastatin, rosuvastatin. In addition, all people who have got coronary plaque or coronary disease, we do put them on aspirin, like a blood thinner, okay, like to try to prevent clotting, etc.
Right.
We try, if there are multiple blockages, we also try to put medications like what we call a beta blockers, which try basically to reduce the rate of the heart pumps in order to protect the heart, so you don't put too much strain on your heart, okay, and injure it. So these are the things that we do in order to help people like your friends that we were just talking about. I don't think that doing yearly scans is going to tell him much. If he gets symptoms, that's a different story. Then at that point, you need to figure out if it's severe, and if it's severe, then you can put a stent, etc. But just doing like routine scanning every year,
that's really interesting. I'll send him this recording because he's a few years younger than me, so he's in like his mid to late 30s, and they didn't tell him they were going to put him on anything. They just said sometimes people with that exercise a lot, because he does like marathons and things like that. People that exercise a lot tend to have this, and sometimes it heals on its own. And if you have symptoms like you're passing out or things like that, then come back. But otherwise, there was no diagnosis of medication at all.
No, this is incorrect. This is not the current practice or guidelines. People, you might have heard about it, people running marathons and collapsing at the end, having a heart attack.
Right.
This is well recognized. We see it every year here. We get marathons around here. People come from the marathon, from the competition, with acute heart attacks. So, so it doesn't matter that you run marathons or not. It matters that whether you are on the right medications to stabilize the plaques that you have in your arteries, in order not to prevent them from cracking and rupturing and causing the heart attack. That's what's important.
Right. Okay. But yeah, I'll tell him to make an appointment with get a second opinion at that.
Right. Yeah. I mean, this is standard treatment. I'm surprised he got this opinion. This is just like a standard management, stabilization of chronic stable coronary artery
Wow.
disease.
So even if he's in his 30s, there's no chance of this thing healing, and he should be on medication for the rest of his life?
He should be, yeah, right, exactly. I mean, I keep telling people really about the youngest person I have had to treat him with a heart attack. Actually, that was quite a few years ago when I was in London. I was at St. Mary's Hospital, and I got a call in the middle of the night to come to the cath lab for someone with an acute heart attack. And that person was a student. I remember him very clearly, from Malaysia. He was 17 years of age, 17. This was the youngest person I've treated with an acute heart attack.
Wow.
Age, if you have got coronary disease, it needs to be treated. Age doesn't really come into it. If you have it, then it has to be treated.
Okay. Fair enough. Thanks for that. I guess that's a good lead into talking more about exercise. So, like, where is exercise, helpful for the heart and long-term longevity, and where is it more risky? Because there are obviously so many people that are doing Ironmans and triathlons and marathons and all these things. So maybe you could give us an idea of like where exercise is really helpful for heart health, and then where it kind of gets into the red zone.
In general, exercise is very beneficial for the heart because it keeps the circulation going, it keeps your body fit. Just like an example, I will start with this one and then I will go in details. I keep telling my patients, look after your body as if you're looking after your car, meaning you have to look after it. You have to make sure the oil is changed. You have to make sure that you don't bang it and crash it. You have to make sure that it's running all the time.
Right.
If you leave it, it's not going to work, etc., etc. So generally, exercise is very beneficial, not only for the heart, for the body in general, and for the whole health of that particular person or any person. Now, before anyone embarks into any of these aggressive sports, which people enjoy doing, and it has got lots of benefits as well, they have to undergo like a physical testing. This is standard if you are at school, if you are in any competitive club, they will ask you to do this. Okay, right. So some people that would rule out significant heart disease, or exclude most of the people with significant heart disease. I'm sure you have heard about people in very competitive fields, in the soccer field or in whichever sport, they just collapse and die. And right. That's because there is already significant coronary. It's structural. Sometimes it's structural heart disease, not coronary. Actually, most of these young people who collapse and have issues in competitive sports have got a structural heart disease, something like hypertrophic cardiomyopathy or some form of heart arrhythmias that develop. They are predisposed to it. So before anyone embarks into these tough sports that you mentioned, they have to have a thorough physical examination and full evaluation, complete full evaluation. And all these people I mentioned to you before, I mean, these people probably have already gone through all these tests, but they passed. So there is still a small minority of people that still get missed in spite of being tested, because these athletes in these clubs that you see, these people have been tested a lot before they go into the field. So, but still a small minority that still get missed, the test don't pick. So, but in general, the majority are picked, okay, and they are advised against being in this competitive field. So, going back to the question, you have someone who has got coronary disease, mild coronary disease. Exercise is definitely good for them, provided that they don't overdo it. meaning that it's within limits. The blockage has got to be non-obstructive. Therefore, there's no obstruction, because if there is an obstruction and you stress your heart, you are going to get a form of heart attack that we call type 2 heart attack, meaning it's supply-demand mismatch. Basically, you are trying to get your heart to give you more flow, to perform, but there is a blockage, and that's what we call type 2 heart. It does not generally present with the same symptoms we described about acute chest pain. That's a different type. So, exercise is generally beneficial. If you are embarking on stressful, tough, competitive ones like marathons, triathlons, etc., Ironman, then you need to have a complete, full physical examination before you do this. Other than that, if you feel fine and you feel well and you haven't had issues before, you can embark on exercise as much as you can and as much as your body can tell you that you can't tolerate. So cardiovascular exercise is obviously the front line for heart health, but also some people do other exercises like lifting weights, etc., to build their bodies. There's nothing wrong with that, obviously, apart from they have to be careful not to injure their bodies in that. So exercise generally is beneficial. The side effect is mainly injuries rather than heart disease. I mean, if you look at the data, actually I think I've got in my website a blog about the benefits and side effects of exercise. The data really looks at it's more like injuries rather than heart disease or anything like that, injuries to the body, etc.
Okay. Maybe, sorry to interrupt, maybe I can clarify. So it seems like from what you're saying, exercise itself is rarely harmful unless either you're doing improper form and you're injuring your body, and that's just more a safety issue. But for the heart, it seems like the only place that exercise is dangerous is if you have an underlying condition.
Absolutely. If you have got you really summed it very nicely. This is absolutely correct.
So under that, you can't think of any exercises that are, or patterns of exercise that might be bad for a healthy heart?
For a healthy heart, no.
Okay.
If your heart is healthy, then exercise is definitely good for you. It's good for your heart. It's good for your other parts, organs in the body, musculoskeletal well-being, etc. And also, apart from physical, psychological, has got lots of psychological benefits, etc. Right. So if your heart is healthy and if your musculoskeletal you are healthy as well, meaning you're not going to injure yourself, then exercise is generally very beneficial.
Okay. You mentioned something earlier on that I'd actually like to hear your take on. So you mentioned in the last several years, people can be more curious about like myocarditis, and it's coming up more in the world. There's still in every country hundreds of deaths per day of COVID. I saw a study the other day that was sent to me that in the UK it's like 1 in 25 people that when they get COVID. In the next 24 hours, they could drop dead. That was a drastic. I just read it the other day, so I didn't really dig too far into the study. I need to do that still, so I don't know if there was an age skew. Maybe it was above 80. Maybe it was a general population. I'm not sure, but so these ideas are still on top of mind. And then you have obviously a lot of anti-vaccine people that think anyone with myocarditis only got that because of the vaccine. So I was hoping you could explain more of exactly what myocarditis is, how it presents, and then how it's subsequently treated.
So myocarditis, in very simple term, is basically inflammation of the muscle of the heart. That's just in very simple term. Okay. Right. It's a rare condition. There are certain causes for it. The commonest causes for causing myocarditis is like viral infections. Okay, and obviously, other things like vaccinations, etc., can cause it, but this is not the commonest causes. Now, when you get any infection, there are certain infections which are known to cause myocarditis, Coxsackie, etc. the COVID virus is also a factor that can cause it. It's not, although it's not one of the top causes by any means for myocarditis. So when you get a viral infection, it's in your system, in your body, any organ can get affected, and the heart is not an exception. So the incidence of myocarditis in COVID is not well defined, and the reason being, we don't scan everyone with COVID to look specifically for myocarditis, because you will need specific tests. And I might backtrack here, now I said it, about more clarification about myocarditis. So there's a wide spectrum of myocarditis. It can go from completely subclinical, you don't even know it, okay, that you have got myocarditis, you don't feel it, there's nothing, to more severe cases in which you get significant inflammation of the muscle of the heart that affects the function of the heart, leading to heart failure, leading to significant serious arrhythmias, etc. So in the majority of people who get viral myocarditis, including the COVID virus, the infection is subclinical.
Okay.
You don't even feel it, you don't even know it.
Right.
So to know the incidence of myocarditis in the general population is very difficult, because you have to be scanning every single person who gets the virus, scanning by doing, like, the best way is to do an MRI scan of the heart. It's just not feasible and it's not possible. Okay. But there has been studies taking 100, 200, 300, 400 people, scanning them for the purpose of the studies. Okay, just to understand about. And the incidence is very high, but most of it is subclinical. It comes on its own with the virus, and it goes on its own. You don't even know it. Okay, so the heart is affected. Yes. Great majority is subclinical, and it heals on its own. You don't need anything for it.
Okay.
There is a very small fraction of people who get the COVID virus infection that get significant myocarditis that presents clinically, and even a much smaller portion that will need, like, intensive care treatment, etc. Like in less than 1%. Okay, this is very, very little information, very little percentages.
Right, and just to be clear, it's like 1% of the population might get myocarditis, probably less, but then 1% of the 1% are the ones that are going to intensive care. Is that what you're saying?
What I'm saying, the percentages from the literature so far, that if you scan everyone, you get it much higher than that. You get it like 20, 30, 40%. Okay, wow. You can get, if you get the infection. Okay, depending on the study you're looking at. But most of these people even don't know about it. They knew about it because the people were scanned. They had scans. So you can get today COVID. You have got the symptoms, etc. You recover from it. You wouldn't even know that you had myocarditis. You wouldn't even know about it. Okay.
Right. And this is something, and it's something that heals on its own over time.
Absolutely, it just takes a few weeks and it goes on its own.
Okay.
Just like you get the flu vaccine, you get the flu virus, etc. You get flu for a few days and it goes on its own. Okay, you don't do much about it.
Right.
So, and a very small percentage of people get really seriously affected. Even smaller will need intensive care treatment or anything for it. Now, regarding the vaccine, okay. The percentages are even smaller of you getting myocarditis. Much smaller. Even getting it myocarditis in the first place. But it is recognized. And anything we do in medicine is risk and benefit. Okay? So the question becomes is that are you going to risk not having the great benefit from having the vaccine because of the very small chance that you might get myocarditis? Today, if you are crossing the road, Michael, you can get hit by a car and get killed. Anyone can happen to anyone, right?
Right.
Are you going to say, I'm not going to cross the road because I have got a very small chance I'm going to be hit by the car? Of course
Right.
not.
You have to walk in a lot of circles to live your life.
Exactly. I
To
mean,
get that.
so yeah, right. So I mean, you are not going to say that, right? So think about it that way. I mean, you have got everything you do is risk and benefit, and you are going to choose whatever the benefit is, or that's what at least I advise my patients and I do for myself. You are talking to someone who had already 5 shots of COVID vaccines. I go regularly and have vaccine. I have had 5 so far.
Right.
I, as a cardiologist, I know that the risk of myocarditis is there, but it is slim. Am I going to say I am not going to protect myself because of the risk of myocarditis? I think that would be harming myself rather than helping myself
Right.
in not taking the benefit. So the risks are there. The risks are small. I have seen patients, yes, who have the vaccine, and after that they have had lots of issues after that. Yes, it can happen. Okay, it's not like it's unheard of or I haven't seen it. But it's risk and benefit. And also, by the way, it's not only the heart. You can get lots of other side effects from the vaccine. Neuropathies. I have seen patients got paralyzed half of their face, or lost the use of their limbs, or neuropathy.
Permanently.
Well, in the great majority of cases, it comes back. So it's the face, paralysis of the face, and great majority of cases, like 90-95%, you know, it comes back. But are you going to say, because I have seen people getting paralyzed, I'm not going in the face, muscle of the face, I'm not going to be Bell's palsy, that's what we call it.
Right.
I'm not going to have the vaccine? Absolutely not. The risk is there. It's very small.
Right. I suppose it's the fallacy where, you know, something that seems more scarier, like getting eaten by a shark or going down in a plane crash, but you don't think about, you know, getting in your car and driving because it's such a regular thing that's baked into our lives. And so you have an idea of, like, you don't want to be that 1 in a million lottery winner or that has your the side of your face or body frozen. So it becomes a much more visceral feel than getting in a car accident, because you know so many people who got into car accidents and they're fine. So it's these things that the human mind doesn't seem to be able to process with any sort of intellectual consideration. It's more feeling based.
Right. I mean, this something has been there for a long time, Michael. I mean, if you look at the previous pandemics like Spanish flu, etc., 100 years ago, this has been the same issues going in the minds of human beings all over regarding the infection, regarding the vaccination, etc., etc. But I think that in the current day and age, unfortunately, with not all the media are very clear, and lots of people have their input, which is fine, but lots of people don't base it on science and facts. Okay, they base it on who do they trust to talk to, etc., which is not scientific. And I think we have to really work on hard to try to get at least the medical information right. And people disagree, even in the medical information, when you put the data. Some people disagree on the facts, but the simple thing I would say is that always look at the risks and benefits. So I know that some people were completely anti-vaxxers and they didn't care about the vaccine, and then unfortunately they lost their lives.
Wow.
The same people who are doing against the vaccine, they got infected with the virus and they lost the virus. So everything is risk and benefit, and that's what I would say.
That's super
just
sad.
Like when we advise for any medical therapy or any medical procedure, we sit with the patient and say, this is your risks and these are your benefits. What would you like us to do? Okay, the same thing. This is your risk.
And those are very hard decisions to make. That's why, some aren't able, and they'll put the decision into the hands of their doctor or maybe a family member, but that's really difficult. And I guess, like, to one more last stop before we get off, like, the COVID world a little bit, I'm assuming you're seeing drastically fewer people in your practice that having to deal with COVID, or is it still an issue that takes up a lot of your time?
No, it is less for sure. I think it's also because lots of people got exposed to it already.
Right.
Lots of people already got vaccinated. So it is less. It is there still, but it is less. I mean, now in my hospital we don't even wear masks. I personally prefer that people wear masks, but this is my own preference, because
Right.
you don't want also you to be a patient in a hospital and the doctor comes or the nurse comes and gives you an infection. Okay, because these people themselves are exposed. They
The
come
basics.
from they come from their homes, as they mix with people, etc. So it works both ways, for the patient and for the physician. The transmission can happen either way, but nonetheless, there is no regulation now to say that you should be masked, in order to see the patient, or the patient has to be masked, as before. Although, as I said, my preference is that it should happen. It protects both the physician and the patient in either direction. Either the patient give it to the physician, or physician give it to the patient. So
Sure.
yeah,
Yeah, that's always a touchy subject in some areas. You think
Absolutely.
it would be less so in a healthcare environment, but this is the world we live in, I suppose.
Absolutely.
To get back into more heart health items, I'm thinking about resting heart rate for a while, because during the COVID pandemic, I think just maybe it was the stress of it and staying inside more often, not moving enough, sleeping patterns being disrupted. I was in the midst of a bit of a stressful relationship at the same time. So I noticed that I bought a Fitbit. I noticed my resting heart rate was creeping up to maybe high 70s, low 80s. And I was getting really concerned. And now over the past year, with the pandemic going away, that relationship ending, me getting more sleep, exercising more regularly, trying to breathe and all these things, I've noticed now it's in the low 70s. And sometimes even when I'm watching TV and I'll take a peek at my my Fitbit and it'll be 67, 68, which is really new for me. So I was wondering if maybe you could explain some of the minutia around the idea of the resting heart rate, of what's too low and what to do, what's too high. Like maybe we can get a little bit of a workshop on resting heart rate here.
So generally, the heart rate should be anything between 60 and 100 per minute. Okay, and as you mentioned, it does differ from person to person according to circumstances and lots of factors. Okay, we mentioned stress, which is definitely a factor, but there are other factors regarding health condition, mobility, the frequency the person exercises.
Right.
So Fitbit, actually, I think the Fitbit and the other, like the iWatch, etc. These are great tools, because, and I'll come to you about that in a minute. But just to give you like a hint, like that, we get people diagnosed for the first time because their Fitbit or their iPhone told them something, and they have got significant issues, and they didn't feel it until that device told them that there is something wrong. So I think that.
What do you mean? Like it showed them they had a high heart rate, or like?
Some people go into very significant arrhythmia like atrial fibrillation,
Right.
irregular fast heart rate. They tell you, all of a sudden, my heart rate has jumped over 100, and
Wow.
I'm feeling fine. And they don't know it. But if they did not recognize it and it kept going, it weakens the heart, because it weakens the heart, leads to cardiomyopathy. It's called it tachycardia-induced cardiomyopathy. Number two, it can cause clots in the heart, and these clots can go and give you a stroke, etc.
Wow.
So it can be a very significant arrhythmia. But these devices now, they pick it, and the individuals come and say, well, I don't know why this is happening. So they are a great thing. Going back to the heart rate, your question. So for people who are generally young or at any age who exercise regularly, the heart rate tends to be on the lower side. As I said, the heart rate is between 60 to 100. Sometimes it even goes lower than that, like in the 50s, and that can be normal for these people because their heart is so efficient. It pumps, the extraction capacity of oxygen from the blood is higher. Therefore, the heart doesn't need to be going in beating like in the normal range. It beats less and it delivers the same amount of oxygenation and function to the body. So in young athletes and young active people, it can be low, okay, and that's absolutely fine. The other end is that when it is high, usually it's either abnormal, such as, like I said, stress, activity, or just lack of general fitness, because your heart has to work harder in order to get the circulation. So you'll find it at the upper end, okay, like in the high, the 90s, 80s, 90s, etc. If it goes above that, above 90s or above 100, then there is something definitely wrong, okay? It's not just like a normal adaptation of the heart to any demand. And that's what I mentioned to you, that we get people coming, oh, my heart all of a sudden jumped to over 100, and we do tests and we find they have got really a significant issue. And that was the first time ever they knew about it. And thanks to the smart devices that they're wearing, it's now being picked.
Wow.
As a matter of fact, I actually sometimes ask my patients whom I know they have got issues, why don't you consider buying a Fitbit or buying an iWatch to monitor you regularly? I leave it to them. It's their decision at the end of the day.
Sure.
So these are the normal heart rates. There are factors that can make them swing either way, towards the lower rate or towards the upper rate. If it goes into either direction, then you have really to think about something going wrong. So, for example, you said now your heart rate in the 70s, right? If all of a sudden you find that your heart rate, for no particular reason, your heart rate dropped to 50, there is something wrong with the conduction system there. Why is your heart rate dropped all of a sudden to 50 for no obvious reason? Or if today the same thing happens in the opposite direction, all of a sudden you're getting a heart rate above 100, even though you might not be feeling it, also you'll be asking yourself, and probably you'll seek advice as to why is your heart rate so high. So there's a range below or above which it can be abnormal. There are 13 factors, stress, activity, general health, well-being, etc., that can make it fluctuate. Or using medications, like for example, if you use inhalers, etc., can make it be high. Or also if you use some medications, can make it low. Sort of factors can make it fluctuate. But going above the range of 60 or above 100, below 60 or above 100, is certainly a serious issue and has to be addressed by seeking medical advice.
Okay, that's noted. Yeah, because I know, like, even when you're just walking around, you can tell, okay, I'm normally walking around, I should be around 90 or 100. And even when I'm exercising, I'll take a quick look just to see where they're, to get a baseline of where I should and should not be. So it's good to know. I didn't know that the base was 60, because I thought runners were always in like the 50s, but you said like the vast majority, like 95% of people, are between 60 and 100.
This is just like the rough idea. If you want to have specifically, there are formulas regarding to age, etc. But right. Generally, you'll find it at 60. Below 60, we label it as abnormally slow, or above 100 is abnormally fast. Okay.
So I guess just to wrap up a little bit, I'm wondering like what we can tell people to deal with their hearts better from the start. Like, is there any, aside from regular exercise and trying not to sit too long, which, I have a remote job, so I try not to sit down too much, but I find myself at a desk, unfortunately, more hours than I'd like. And is there any supplementation that you hear is good? Like, is magnesium or beetroot or frog's tail or something like that? What sort of ideas and supplementations would you recommend?
So, as I mentioned during the discussion, I would say look after your body as if you look after your car. If you want your car to last, you need really to do certain things for it. In order to have to maintain it regularly, go and take it to maintenance, regularly to be checked, make sure nothing really is not functioning. Right. Make sure that you don't abuse it and you don't crash it. Okay. Make sure the oil is changed. Make sure it's absolutely all the time running. Otherwise, if you leave it not running, it's just not going to work, even though you haven't used it. So, what I say for general health, abide by the heart healthy lifestyle and heart healthy diets, etc. Heart healthy lifestyles means that you at least you have to move your body. The recommendation is like you use like 30 minutes of like fairly active exercise every day for 5 days a week. So brisk walking, jogging, etc. 30 minutes 5 days a week is absolutely fine. So you have to keep doing that. If you do exercise, you've got a sport person, that's brilliant. If your body can tolerate it, go ahead and do it. So these are important regarding mobility and having the heart fairly active and being in good shape in order to maintain the circulation, etc. Also, apart from that, it's no good doing all this and then eating like junk food and bad stuff, because this is going to build up in your coronary arteries and it's going to, or arteries all over the body, including the neck, the arms, etc., and cause blockage to the flow of blood and reduction of delivery of oxygen and nutrients to particular organs or to the muscle of the heart.
Okay.
So the most studied diet and the one I recommend and the one that I try to abide to by myself is the Mediterranean diet. And the Mediterranean diet is basically eating lots of vegetables, eating white meat like fish and chicken. And in the Mediterranean diet there is olive oil. The extra virgin olive oil means unpurified olive oil has got lots of nutrients. So exercise and good nutrition is very important. Try not to take red meat a lot because it's harmful. I don't say to my patients don't eat it at all. I say don't eat it more than once a week.
Right.
That's it. There is the red meat. So these are the guidelines and things that I try to abide to myself, to keep myself fit and healthy. Now, supplements. There has been no studies showing particular benefits of supplements, Michael.
Okay.
Yeah. So above and beyond. So if you eat a healthy diet, all your nutrients and vitamins and everything is there. Some people take magnesium because of the immunity now with COVID, etc. It improves magnesium, improves well-being. Some people take other supplementation, which is the other ones are justified, like for example calcium and vitamin D. Lots of us are indoors, including myself, unfortunately, because of my job. So we don't get enough sun, etc. So when I measured my vitamin D a few years ago, it was quite low. So it wasn't a surprise, and that's actually true for lots of people who work indoors. So supplementation like that are justified when you have got like low levels because of factors that you are not exposed enough to the sun to manufacture your own vitamin D, etc. Calcium. Women after a certain age, they need calcium, magnesium. So there are certain ones which are justified, but generally for everyone just to take supplements, to improve their well-being, is completely unnecessary. Some people feel fine about it. I would say don't go above and beyond. If you would like to take supplementation, just take like one tablet multivitamin, contains everything, and that's it. But I find lots of people coming to me to my clinic have got like a full range of array of every single vitamin in a single tablet. Right, exactly.
The amount of advertising on social media and everywhere for supplements is unbelievable.
Unbelievable.
Like if you go on even Amazon.com and look through the supplements, it's like we cannot get supplements from food. There are so many supplements out there. It's crazy.
Completely unnecessary. You spend a lot of money in it. Has got no proven benefit. It's very expensive, by the way. As you said, it's an industry.
For sure.
The amount of advertising is, because it's an industry, it brings income to these companies. That's why they advertise heavily for it. So generally, it's unnecessary. If you want to take something, just take like a multivitamin, covers everything. But in the great majority of cases, it's has got no proven medical benefit.
Right. That's great. Hopefully you save people hundreds of dollars a month with that.
I have
with that idea.
I have seen people really spending $500, $600, $700, and they bring it. And vitamins actually sometimes they bring something and I say, what is that? I mean, I think that sometimes someone brings something I haven't heard about at all, and I have to go and look it up. What is this person taking? completely unnecessary. But as you said, advertising, it's an industry.
Yeah.
Some people buy into it, and they buy it and spend a lot of money. It's a fortune every year for
Yeah.
things which are
Like
completely.
for example, I've definitely felt benefit with taking like 200 milligrams of magnesium every day, more for like muscle health and things like that. But anything else, I kind of try to stay away from until, more than enough of consensus has been built that this is going to be good. Like I keep getting people telling me to take fish oil, and I'm still looking into it, and I've tried it a couple times, and it kind of doesn't make me feel that great. So I've not seen any benefit from it as well. So maybe I'm wrong, but I don't know. I don't know enough.
I think if you are fit and healthy and you eat okay, you definitely do not need this. Except in very rare circumstances, which there is specific deficiency for a specific disease, because some people have got specific disease that prevents them from absorbing. But
Right.
apart from that, if you are a healthy person um, eating healthy food, you really don't need it.
Right. Okay. Well, thank you very much for that. Hopefully, we've helped some people today get some a better idea of how to manage their own health and their heart health. And it seems like you're doing a great service to the people of Indianapolis.
Well, thank you. And I just want to say that I answer every day like 40, 50 questions from people from all over the world. People just write to me, and I've got on my website, and I try to help as much as I can. Actually, I answer almost all of them every day. So anyone who has got a question about anything, they can always reach out to me on my website, which is drbolad.org. The full word, Dr.
Okay.
DoctorBolad.org. They can ask me any question, whether someone's concerned about this vitamin issue. I have got some videos on my website that can explain a lot, and it does explain a lot about that. But if they have got any question, anytime, I do answer all my patients.
That's great. They even look at those people writing to you as patients. Like I'll tell my friend to send you a message, because I have a feeling I got the diagnosis wrong for their arterial branch, that it's something else entirely. So I'll tell him to send you a message and get a better idea of maybe what he should do.
Sure, absolutely. I'm happy to help anytime, Michael.
Okay, I appreciate it. Have a great weekend.
Well, and same to you.
Bye bye.
Take care.
So thanks for listening to No More, No Less. I appreciate the time you spent with me today. So please subscribe and rate the show if you enjoyed it. It'll help me create more amazing content and get that next little bit of validation that I so deeply crave. If you did enjoy it, well, that sucks. But to make sure, I think you should listen to my next 10 episodes and then decide. I mean, come on. Rome was not built in a day. I'm just getting warmed up here, guys. So thanks again. See you next time.